Okay, good evening. Welcome back. Thank you for coming back again on today for our rearranged session all about wheeze in children. I'm joined this evening by Dr. Sheryl Abraham, who is an SHO, who's currently working in paediatrics and also hopes to pursue a career in paediatrics. She'll be taking us all the way through wheezes in children, something that anyone that's seeing children at the moment will hopefully have a fair bit of experience with. As always, please do get involved. If you have any questions, do stick them in the chat. I'll be here for the whole webinar, so I'll be able to relay any questions onto Dr. Abraham. And also, if we have some questions for you guys, please do just shout out the answers, stick them in the chat, and get involved. So over to you, Dr. Abraham.
Thank you. Thanks, James. So as James is very succinctly, and I don't think I need any more of an introduction, so we'll go straight into it. I think wheeze in children at this time of year is probably the most common paediatric presentation that you will see, either if you have a paediatrics job or if you're working in A&E. This is, I think, the main things that you will see during the winter months, and it's actually happening a lot earlier as well. So I think early September, October time, we were seeing a lot of the wheezy presentations, where previously it was kind of December, November time. And there's also been a massive surge in RSV, which is one of the main causes of respiratory distress in children. So in terms of what I wanted to go through today, and as James has mentioned, feel free to ask questions as we're going on. I don't mind being interrupted if anything doesn't make sense. You can just use the chat function. But I think the main learning objectives for today is just to understand why exactly children are more likely to present with a wheeze, how we would assess the severity of wheeze presentations. So a lot of these children can just go home after a period of observations, but some of them will need to stay in hospital. So how do you assess the severity? And that also will dictate what treatment you give. Understanding kind of common differential diagnoses for childhood wheeze, which also varies a lot with age, and just how we manage various wheeze presentations. So why exactly is wheeze more common in children? Obviously, adults are also prone to having a wheeze. In adults, most commonly is asthma. But in children, because their airways are essentially smaller, they're more likely to have increased resistance in their airways. And that can increase the pressure, essentially, in your intrathoracic airways. So I've put this equation at the top. It's not something that you might need to learn, but essentially your peripheral airways is equal to your resistance. So your peripheral, the smaller peripheral airways is due to resistance, which is essentially 1 divided by your radius to the power of 4. So children will have a smaller radius, and because of that, the resistance is greater. So that's what the equation essentially explains. In newborns especially, their chest walls are very compliant, so they expand and collapse very easily. And that increased intrathoracic airway collapse is due to kind of inward pressure produced in expiration. And that's why newborns actually have quite a high risk of presenting with wheezing. There's also things like difference in tracheal cartilage composition, which is not as strong as adults. And just the general airway muscle tone. And there's also immune factors, so they have more lymphocytes and neutrophils in their BAL, which is like the fluid in your bronchioles. So essentially a wheeze is more due to your intrathoracic airway narrowing. So that's in contrast to like a stridor, which is more your extrathoracic airways narrowing. And because if you think about, could you go back a slide? Thank you. If you think about your actual inspiratory and expiratory phase of breathing, when your intrathoracic airways narrow, that is predominantly your expiratory phase, and that is why a wheeze is an expiratory sound. So an acute wheeze is essentially due to partial obstruction of your intrathoracic airways, and there are various reasons why you can get obstruction in your intrathoracic airways. So it could just be due to inflammation of the mucosa, which we see in things like bronchiolitis. It can be bronchoconstriction, which I'm sure you all know is the main pathophysiology for asthma, or it could be a mechanical obstruction. So something like a foreign body is something that you need to rule out in a child presenting with a wheeze. So how do we assess a child with a wheeze? So the first thing you would want to do is take a history. Obviously, if a child comes in very unwell, we would go straight to the examination first and then take a history. But if a child is able to, obviously you're actually going to get most of the history from the parents. So things we'd want to know are their age. The reason why age is so important is because different ages present with different causes for wheeze. So essentially, your bronchiolitis type babies, more common in the kind of first 1 year of life. Between 1 to 5, it's very common to have a viral wheeze. And then after 5, you see more asthmatic children. So after 5, your viral wheezes tend to kind of fade out and you get more of an acute exacerbation of asthma. There's also something called multiple trigger wheeze, which I will talk about a bit later. So in a history, you'd want to ask about onset. So things like an acute exacerbation of an asthma will have a very quick onset of a wheeze, like maybe a few hour history of a wheeze. Atopy is also really common. So with asthma, so if you have an atopic asthma, you're more likely to have conditions like hay fever and eczema. You also want to ask about a family history of atopy as well, and a family history of asthma, because those children are more prone to having a viral wheeze and also developing asthma. Coryzal symptoms are really important, especially in bronchiolitis, which is essentially a viral infection which causes the wheeze. These children present with like a 2 to 3 day history of like a runny nose, a cough, and then they will have their wheeze. So these kind of give you ideas as to what your diagnosis is going to be. Similarly with a fever, so a fever is more likely to be a viral wheeze or a bronchiolitis rather than an asthma, unless it's an infective exacerbation of an asthma. Feeding, as in all paediatric histories, is really important. So if a child's having reduced feeds, that's going to indicate the severity and a reason for admission as well. And that goes as well with growth and failure to thrive. Birth history is also really important. So, for example, preterm babies, because their airways are smaller, they're more likely to develop a viral wheeze. And also if you have respiratory conditions in your neonatal period, like meconium aspiration or bronchopulmonary dysplasia, those type of things, you're more likely to be at risk of severe bronchiolitis. So it's really important to get aspects of the birth history when you're speaking to the parents as well. Pets and smoking, these are all triggers. So even if babies are not necessarily, a lot of the time parents will say that they do go outside to smoke, but it's not really good enough, because those smoke particles stick on their clothes and things like that, and babies will inhale them, which increases the risk of basically essentially all respiratory conditions. And previous HDU and ITU admissions is really important for your bronchiolitis and asthma wheeze children. So you just know that they present with this more severe form of the illness. And drug history, so you want to know if they're on any inhalers. Are they compliant with their inhalers? Do they, just take them once a month, or do they take them, every few weeks? So that's also really important. Peak flow. Essentially, a peak flow is only really accurate after the age of about 5. So it's useful if I haven't known many people that actually do regular peak flows. as a child. But it's worth asking if they are a known asthmatic, if they do peak flows, and what are their values, etc. In an assessment, you would do a peak flow, probably towards, it depends on like how unwell the child is, but we do use peak flow to assess the severity of asthma. Heart rate and respiratory rate, also really important criteria that we use to assess severity. Confusion, so that's like GCS. Agitation, so if they're getting drowsy and tired, or if they're getting agitated, also really important. Respiratory distress, so this is really important, and probably the most important way to know if a child is really unwell. So is looking for your signs of respiratory distress. And I've got a few videos that you guys can watch later, or we can show at the end if we have time. So your moderate signs would just be if your heart rate and your respiratory rate are raised. You might see nasal flaring where the nostrils get a bit wider, use of accessory muscles, your intercostal and subcostal recessions, head bobbing. So they're more moderate signs, definitely signs that they're unwell, but moderate rather than severe. And your severe signs will be things like cyanosis, tiring because you've just got increased work of breathing, reduced conscious level. In asthmatics, we sometimes see something called a silent chest, where you cannot hear breath sounds at all on auscultation, and your oxygen levels being less than 92% despite oxygen therapy. So that indicates a very severe asthma or bronchiolitis. So I'm going to talk about these three conditions because these are going to be your most common causes of wheeze in children. There are rarer causes that I think you should always exclude in a differential diagnosis, but these are your main three that you need to know about for exams and just for treatment. So case study 1. So this is a 7-week-old infant. So she presents to A&E. She's born at 35 weeks. She's breastfed. She presents with rhinorrhea, which is essentially a runny nose, lethargy, poor feeding. On assessment, you see mildly increased work of breathing. She has one brief apneic episode. Her oxygen sats are 93 to 96%, so essentially that's fine. Afebrile, and otherwise it's a normal physical examination. So she's got 2 siblings at home with upper respiratory tract infection symptoms. Ooh, there we go. So I think because of the age range, you can probably guess what this is. So this is a presentation of bronchiolitis. So what is bronchiolitis? It's an acute viral inflammatory illness of your smaller airways that occurs in the winter epidemics, and it affects children aged under 2 years. Peak incidence is around 6 months. Your most common bugs, I think this is a very common exam question, is RSV, which is about 80% of bronchiolitis cases. But you've also got other causes such as rhinovirus, adenovirus. If you have co-infection, so like an RSV and another virus that is meant to cause a more severe form of bronchiolitis. The course of illness is about 2 weeks, and most of the time they're actually just quite well and they self-resolve, but sometimes they do need hospital admission. Very rarely it can cause permanent damage to the airways, and this is called bronchiolitis obliterans. I think it's quite common when you've got RSV and human metapneumovirus, when those two are together, or it might be adenovirus, actually, might be wrong. In terms of how these present, so as I mentioned before, they have these coryzal symptoms for about 2 to 5 days before the presentation. They might also have a cough, which is sometimes paroxysmal. They'll have this intermittent wheeze, irritability and poor feeding. They might have a mild pyrexia, but it's very rarely very high. So very rarely it will be higher than 38.5. Respiratory distress with a progressive tachypnea, flaring, nasal flaring, intercostal recessions. They might have these periods of apnea or hyperventilation, which are quite common, which is just due to tiring. Hyperinflated chest on examination, and when you listen on auscultation, the classical findings are widespread fine crackles and a wheeze, which is over both lung fields. As bronchiolitis is going to be your most common differential in children, kind of less than 2 that present with these kind of symptoms. But you should always have in your back of mind that there are other causes, especially if babies are not responding to conservative management, which is essentially how we treat bronchiolitis. So differentials that are always important to bear in mind are a recurrent viral-induced wheeze, which can happen at this age. Early asthma, so babies can have asthma from a really young age. Cystic fibrosis, which is can happen with like recurrent chest infections. You need to rule out cystic fibrosis. Pertussis, and you're like whooping cough. Recurrent aspiration. Foreign body in your trachea, or a congenital lung anomaly. So those are all important things to bear in mind if a child is not responding well to treatment and they're getting repeated episodes of bronchiolitis. So this is a video. I think maybe we can watch it if we have time, or I don't mind if we watch it now. What do you think, James? Should we watch it now if we can play it?
Let me just see if I can get it working.
Might not work. Oh, it's...
Sorry.
Thanks, James. So yeah, I thought that was just a really nice video that was made during an RSV awareness week, just to show exactly what these babies look like when they come into hospital. So this picture, I got this from the Sunflower textbook. I don't know if there's any medical students listening, but the Sunflower textbook is what I used during med school, and it's got really nice images and pictures for learning and things. So yeah, they'll have this like noisy breathing or a dry kind of wheezy cough. Their cyanosis and pallor is in the kind of severe stages. Hyperinflation of the chest, which just looks expanded. Your sternum might be quite prominent, or your liver displaced downwards. Obviously, you get these subcostal and intercostal recessions. And you get these fine end inspiratory crackles and a prolonged expiratory wheeze, which are your classic findings in bronchiolitis. So yeah, I think that's it. Oh, so we've just got to talk about investigations and, of course, how we manage it. So say if a child comes in, you're suspecting a bronchiolitis, the key investigations that you want to do is a pulse oximetry. So you want to see how their oxygen sats are doing, and I'll talk a bit about target oxygen sats for bronchiolitis a bit later. An MPA is a nasopharyngeal aspirate, and what we can do with them is essentially test for a whole host of viruses. So one of them will be RSV, but would also test for things like influenza, adenovirus, those kind of things, essentially like an extended viral swab. You also might want to do a chest X-ray, not routinely needed unless there are signs, so a severe respiratory failure is suspected, or if you've got, say, focal pathology, so you hear just crackles in one part of the lung, or essentially you might see chest asymmetry. So those kind of things might point you towards a chest X-ray. Similar with blood gases, only really needed if you're seeing signs of respiratory failure. A blood gas is important because sometimes that does dictate oxygen therapy in bronchiolitis. So routinely, actually, if you've got a child with moderate to severe respiratory distress, we do tend to do blood gases. So the hospital admission, I pulled these from national guidelines. So hospital admission is generally if you've got periods of apnea observed or reported. So even if the parents say there was an apneic episode, but also we like to keep a child in to see if we see those things. Oxygen sats of less than 92% in the early phase of the illness. And that's quite important because essentially the trajectory of bronchiolitis is that it gets worse around day 4, day 5, day 6, and then it gets a bit better. So if your oxygen sats are less than 92% in the very early phase of an illness, that's not a good sign, because the first kind of few days is when the child is the most well. So you'd expect your oxygen sats to be above 94, 95. And then you expect kind of it might dip to below 92 day 5, day 6. So essentially it depends. We don't really tend to put a target sats until we know what day of bronchiolitis they are. An adequate oral fluid intake is really important. So we tend to say less than kind of 50 to 75% of normal is inadequate. And then we need to keep them in to observe feeds, and they might also need supplementary feeding. Severe respiratory distress or a respiratory rate over 70. Underlying cardiac defects, or if you're just not sure, so diagnostic uncertainty. So how do we manage a bronchiolitis? Essentially, most of it is conservative management. So you might want to clear some of the airway by suction, either through the nose or the mouth. Saline drops are essentially a lifesaver. What they do is, if you essentially put a drop in each nostril before feeds, it just kind of clears the airways. So babies are very much breathe through their nose, essentially because of the anatomy. Their mouths are really small, so they breathe a lot through their nose, and that's why their breathing gets really affected, because their noses just get really blocked and stuffy and they really struggle with their breathing. So the saline drops essentially help open up the nose and just help with their breathing. So we tend to give them just before their feeds, because that's when they're most, their kind of respiratory distress and oxygen sats tend to dip while they're feeding. So in terms of oxygen therapy, we can give oxygen via a face mask with a reservoir bag, or nasal prongs, 1 to 2 litres per minute. If they are less than 3 months or have comorbidities, we tend to prescribe oxygen if the saturations are less than 92%. So essentially you'll have a lower criteria. When we actually give humidified oxygen, so this is the main reason why we might admit a child, is to put them on humidified oxygen. So that depends on respiratory distress, or essentially a blood gas. So say if you take a blood gas and the CO2 levels are very high and you see a respiratory acidosis, that child needs help to essentially get rid of the excess carbon dioxide. So essentially how humidified oxygen works is it's something that we call PEEP. which is positive expiratory airway pressure. I forgot actually the E. I've forgotten what the second E stands for. But it's very similar to CPAP, but essentially what PEEP does is it keeps your airways open, whereas CPAP is actually slightly different. But I don't want to go into the kind of physics, and I don't think that's needed. But ERVO just essentially, humidified oxygen essentially keeps the baby's airways open so that it's essentially helping with the expiratory phase. In terms of when we give them fluids, that would be if the fluid intake is just, in terms of fluid intake, is not enough. So if from bottle feeds and NG feeds the child is still not getting enough, then we can supplement with IV fluids or NG fluids. But we tend to restrict this to 80% of maintenance. So we know that babies during bronchiolitis, they don't need 100% of their feeds. So they tend to only need about 2/3 of their feeds. So that works out about 100 mils per kg. Normal is 150 mils per kg, so 2/3 is 100 mils per kg. And this can be either through bottle feeds, breastfeeds, solids if they're weaning, or NG feeds. But that's a really important thing, is we don't discharge until they've actually met 2/3 of their feeds. CPAP and mechanical ventilation, that would be if a child is not responding to humidified oxygen and they've just got persistent respiratory distress, persistent hypercap, like raised CO2, and respiratory acidosis. They may need CPAP or ventilation, which can happen in bronchiolitis. I've seen, I think, 2 or 3 cases that have been intubated and ventilated because of severe bronchiolitis, so it does happen. Sometimes, actually, if these babies have a temperature, so above 39, we do start them on antibiotics. So especially if they're less than 6 weeks, or even actually for us, if they're less than 3 months and have a fever, we tend to start a sepsis protocol, which involves antibiotics, just because we're assuming there's bronchiolitis, but they may have a bad pneumonia, which has caused sepsis. So obviously before you do that, you'd want to discuss things with a consultant. I've put Ostalmivir in brackets because I think they only tend to, Ostalmivir is an antiviral, so say if from your viral swab someone is flu positive, we can give an anti-flu medication, which is Ostalmivir. But I think they only tend to use that actually in immunocompromised babies, so it's not routinely used. And then very importantly is prevention, so things like good hand hygiene is really important to educate parents on. Cohort nursing, so we tend to keep children who are well away from bronchiolitis babies to prevent spread. Gowns and gloves, so PPE. And palivizumab is essentially a vaccine against RSV, and it's incredibly expensive. And I think, again, I've only known one baby who's has fit the criteria to receive it. It's essentially if a child is very immunocompromised and prone to having repeated episodes of bronchiolitis, sometimes they will meet the criteria for receiving that. So I think that's it for bronchiolitis. If anyone has any questions, feel free to put them in the chat. So our next case study is a 5-year-old girl who presents to A&E with dyspnea, wheezing, and chest tightness. She had a recent upper respiratory tract infection with cough, congestion, and a runny nose with a low-grade fever. The mother states she seems to get relief from a blue inhaler that was prescribed previously, and she has a background history of eczema, and her mother also has asthma. Her father is a smoker, but mother states that he smokes outside. So when you come to assess Annie, she has the following. She has intermittent coughing, expiratory wheeze, subcostal recessions. She has a temperature of 37.3. Her heart rate is 100, respiratory rate 40. Her oxygen saturations are 92%, and she's got purulent mucus from her nose, and she's catching her breath often while speaking. sure why the slide's not changing. Oh, there we go. So this is a case of childhood asthma, so an exacerbation of asthma. So asthma is actually the most common long-term condition among children and young people. It has about 1.1 million children currently receiving asthma treatment. So it's something that's really important to know about because it's the most chronic pediatric chronic condition. And actually the UK is not very good with managing severe acute exacerbations that come into hospital. I'm not quite sure why, but it's got a statistic that it's not very good at doing that. I'm just going to talk about key features of asthma. This applies to adults and children, so it's good revision. So this is really important for establishing the difference between asthma and a viral wheeze, because a viral wheeze will not have these features, not all of these features. So with asthma, you'll get interval symptoms with a positive response to asthma therapy. So what are interval symptoms? So there'll be things like exercise-induced shortness of breath or wheeze, things like a nighttime cough or an early morning cough. Essentially, the wheeze is not just triggered by a virus. It's triggered by triggers like pets, dust, allergies, those kind of things, exercise, etc. And then you get those asthma symptoms more frequently, essentially. Diurnal variability I've already mentioned, so things like a nighttime cough or early morning cough. So essentially the symptoms vary throughout the day, but very common is that the symptoms are worse early in the morning or late in the night. A polyphonic wheeze is a key feature that you'll find on listening on auscultation, but obviously you will also hear a polyphonic wheeze with a viral-induced wheeze. And then a personal family history of atopy, so things like hay fever, eczema, or a family history of asthma. I think most children who have asthma have at least a family history or a kind of atopic history. So those are, I think, the key 4 things for as a diagnostic feature of asthma. So this slide, I think, nicely summarizes kind of the pathophysiology of asthma. So essentially, there are the 3 things at the beginning, I think, are what contribute to this bronchial inflammation that you get in asthma. So you get this genetic predisposition, so like this family history of asthma or family history of atopy, or actual atopy, the child has atopy themselves, so like hay fever, eczema, etc. Or environmental triggers like respiratory tract infections, allergens, smoking, exercise, even things like stress and anxiety, or chemical irritants. And that essentially causes your bronchioles to inflame, which causes edema, excessive mucus production. And then what happens is your bronchioles become hyperresponsive, and then you get this exaggerated twitchiness to an inhaled stimuli. And that's what causes your airways to narrow, but you get this reversible airflow obstruction with asthma, which means that it will respond to bronchodilators. You will have this peak flow variability with bronchodilators. Symptoms which then lead to your symptoms of like your wheeze and cough, breathlessness and chest tightness. So I think that's quite a nice diagram to summarize asthma, really. So how would we investigate if we're suspecting a child comes in with asthma? I think I mentioned right at the beginning that we see the kind of asthma children, the kind of how it works with age is that asthma tends to appear in children kind of after the age of 5. So how we would routinely investigate this if we were suspecting it is actually just a history and examination. So that is kind of a key diagnostic thing for asthma. There's no investigation which we say is used to diagnose asthma. I know that's quite different to adults, because obviously in adults we routinely use spirometry to diagnose asthma and COPD, etc. But that's not the case for children, because actually most of them cannot do spirometry. They won't sit still, or they won't be able to understand the test. It's essentially history and examination, and those key features that I've mentioned before. So a chest X-ray is not routinely performed, but again, like in bronchiolitis, if you see signs of like severe respiratory distress or chest asymmetry, focal pathology, then you will of course do a chest X-ray. You can do skin prick testing. So for those of you who don't know what skin prick testing is that essentially it tests for allergies. So they actually put a little bit of whatever they think the allergy is on the skin, and they see the reaction on the skin to see if they're actually allergic. So if someone has, you can see if they've got an atopic history, if that makes sense. Peak flow, we only tend to do this if the child is over 5 years, but obviously if they come in with an acute asthma attack, we do use peak flow to assess severity. Blood gas, again, we don't tend to routinely do a blood gas, only if you see signs of severe or life-threatening asthma, which can happen, and it's very important to dictate whether they again might need CPAP or ventilation. So these tests that I've mentioned at the end, they're not required. They can be done, but they're not required. So spirometry, this is exhaled nitric oxide, and peak flow variability can also be used, but none of them are required. So they're just useful things to know. So in terms of differential diagnosis, again, as I mentioned in bronchiolitis, I think it is important to consider these things if a child is not responding well to asthmatic treatment. So in children aged less than 2 years who have an initial poor response to beta-2 agonists administered with a good technique, you should continue treatment if it's severe, but you should always consider an alternative diagnosis and other treatment options. So some of these are very similar to bronchiolitis, so the things like cystic fibrosis, aspiration, but obviously things like an inhaled foreign body, a pneumothorax, a tracheobronchomalacia or a DKA. You need to kind of maybe consider these diagnoses at the back of your mind. I think someone in the chat has mentioned that the talk has frozen. Don't know if that's. I hope everyone can still hear me.
Yeah, no, it's not frozen for myself.
Okay. We'll continue. So yeah, really important that you consider those differentials if you're still not sure. So this is from your BTS guidelines. That you can find this PDF online. It's really easy to access, and I definitely mention. I would definitely recommend looking up through them. But I've put the key things in this slide that I think that I got from the BTS guidelines on asthma. So the main things is actually diagnosing severity. So this again is different to adults. So I think in adults it's moderate to acute severe to life-threatening, whereas in children there isn't a mild to moderate, an acute severe and life-threatening. It's just acute severe and life-threatening. So your key things that are going to differentiate between an acute severe and a life-threatening is your peak flow. So your oxygen saturations are the same. So if they're less than 92%, you know you've got an asthma which is severe, which is, or not really responding well to oxygen therapy. If your peak flow is 33 to 50% of best or predicted, then we say that's an acute severe. Whereas if it's less than 33% of best or predicted, we say that's a life-threatening. If they're struggling to complete sentences in one breath, or they're too breathless to talk or feed, we'd say that's an acute severe. And then your tachycardia and tachypnea is different for various ages, which I won't read them all out. But essentially, if they're tachycardic and tachypneic, that's on the side of severe. Your life-threatening signs are really important to know and identify. So things like exhaustion and lethargy and drowsiness, hypotension, cyanosis, a silent chest, which I think I mentioned before, is essentially when you won't be able to hear any breath sounds on an auscultation, and that's essentially because the child is so tired. Then again, like poor respiratory effort and confusion or an altered GCS. So when would we actually admit a child? So essentially, if a lot of parents know to actually increase the salbutamol dose, so giving 1 puff every 30 to 60 seconds, and then they can increase the number of puffs to a maximum of 10 puffs. A lot of adults do know that, but we tend to say that if a child has had their maximal 10 puffs via salbutamol, or if they've, as in via inhaler or a spacer, then they should ring 999. So your maximum is 10 puffs, and then they need to call an ambulance. If symptoms are severe, after you've given your bronchodilator, they still need to go to hospital. Paramedics often do give administered nebulized salbutamol, and often they actually can give nebulizers and oxygen together, and they'll tend to do that while they're transferring the child to A&E. So if a child's not responding to an inhaler, they need a nebulizer. And yeah, if they've got severe or life-threatening asthma, they need to be transferred to hospital urgently. And we tend to, again, consider inpatient treatment if the oxygen sats are less than 92% in the air after an initial bronchodilator treatment. So this slide is very busy, but it's a really good summary. I don't know if you'll get a copy of these slides or if any of you want to take a picture of it. So it essentially tells you what exactly, I'll break this down very quickly. It tells you how we treat a mild, moderate, and a severe or life-threatening asthma. So your mild to moderate is going to be your most common presentations that you get to hospital. So they'll have very mild symptoms, like a mild wheeze. The oxygen sats will be fine. Their peak flow will be above 50. What we tend to do is we'll give them salbutamol 2 to 10 puffs via a spacer. We might give them oxygen if they need it, and we tend to give prednisolone. So for all actually exacerbations of an asthma or a viral wheeze, we routinely give oral prednisolone, and that's because we know that the pathophysiology is that the airways are going to be slightly inflamed, and prednisolone, as you know, is a steroid and will help with that anti-inflammation. So we tend to give a 3-day dose, and the doses vary between age, but you don't need to know those off by heart. So very importantly, as in with all of these, with mild, moderate, severe, life-threatening, is that you assess every 15 to 30 minutes. So if they've met discharge criteria, they can go home. So discharge criteria will be if they're maintaining their oxygen sats, and if we know that their respiratory rate and heart rate come down depending on their age, and their peak flow is fine. Very importantly on that last point is that they're stable. They have to be stable on 4-hourly inhaled treatment. So we cannot send a child home until they've been free from nebulizers or inhalers for 4 hours. Once they've met that 4-hour criteria, we can send them home. And what we actually tend to do is they'll have 10 puffs, and then we wean them down to 6 puffs, and we can send home on 6 puffs, and they'll be sent home on a Wheeze plan, which I'll talk about a bit later. So yeah, I think I've mentioned those things. They should always probably have a just in general patient education, so how to use inhalers, and check the inhaler technique. Some will have follow-up with consultants, but they tend to be the more severe side, or they might have like community nurses that come in and check on these children. Moving on to the severe and life-threatening. So this is going to be your important side into what management we give. So we've already talked about how we'd say something is severe and life-threatening. So in terms of severe, we would initially still treat that with high flow oxygen and salbutamol 10 puffs via a spacer or a face mask. So if after giving 10 puffs, we can still see the child is working very hard, they're still very wheezy, then we can try nebulized salbutamol. And we know that nebulizers actually just open up the airways better than than actual inhalers. So sometimes they do tend to work a lot better. So the actual dose of salbutamol will vary between age. We give a smaller dose if you're less than 5 and a slightly bigger dose if you're older than 12. If you get a poor response from nebulized salbutamol, you can then give ipratropium bromide. And it tends to work quite well when we give a combination. So we give salbutamol and ipratropium bromide. So we call that mixed nebs. And what tends to happen, I don't know if you've seen this in A&E, is that they refer to it as back-to-back nebs. And essentially what that means is the child gets nebulizers basically every kind of 10 minutes. They'll get back-to-back nebs. And it's common that they might have 3 or 4 nebs until they go on to just the inhaler. And what is quite common practice is that we'll give maybe 3 nebs. They might have 1 salbutamol neb, 1 ipratropium neb, another salbutamol neb. But quite importantly, before you give each neb, you need to assess the child. So you give 1 nebulizer, then a doctor will need to assess the child, then decide if they need a further back-to-back neb. So between each neb, there should be an assessment. But it tends to, after their nebulizers, they tend to go down to 10 puffs. 2 hourly is quite common. And then we can essentially stretch the inhalers. So 2 hourly, 4 hourly, then we know that once they're on 4 hourly, they can actually go home. And then I've already spoken about prednisolone. So it should be for 3 days, ideally. If oral steroids are not tolerated, we can give IV hydrocortisone, but I think steroids are really strongly encouraged. So essentially, if by that time you've given all those treatments, if they have met the discharge criteria, they can go home. But if they haven't, you need to admit them. And essentially, some of these children might go on to have life-threatening asthma. So with a life-threatening asthma, essentially, the initial treatment will be the same. So your nebulizers of salbutamol or ipratropium to see if they have a response. It might be that actually they have signs of shock, so they might need a fluid bolus or just IV maintenance fluids. And then we can also now consider additional drugs. So if they're not responding well to nebulizers and you still see these signs of life-threatening asthma, we tend to consider IV salbutamol or IV magnesium sulfate. I don't think aminophylline is mentioned on this particular guideline, but that is also one that's used in common practice. Obviously, you would refer to your trust guidelines to see what exactly they give. These are just generic national guidelines. If in terms of a salbutamol bolus, the kind of details of drawing it up and everything are here, but I wouldn't say that's too important. Unless when you come to prescribing it, obviously it's important to know the dose, but I wouldn't worry about how to draw it up and everything. But very importantly with monitoring is that these children need to be on continuous monitoring, so continuous heart rate and respiratory monitoring, continuous oxygen and carbon dioxide monitoring, and ECG monitoring. And you will also need a baseline use and ease, which is really important for IV salbutamol because it can cause hypokalemia. So after you've given a salbutamol infusion and it's still not working, then you can consider your additional things like IV magnesium sulfate or aminophylline. So with all these children, so with life-threatening, you would do a blood gas and a chest X-ray. You need to rule out that there's nothing else going on. And also you need to see if they are in respiratory failure. So type 2 respiratory failure would be your most common that you would see, that they're just retaining their carbon dioxide. And if it is persistent, they might then might need to go on to CPAP or ventilation. So yeah, I think that diagram is a really good summary, but of course refer to trust guidelines.
Sure. Have you seen there's a couple of questions in the chat?
Oh yeah, I have. So inhaler question. If in primary care, needing escalation control, already on Montelukast and high dose ICS, needing better control, what does your area start on Severity? I will actually have got, I think it may be my next slide, I've got the stepway ladder that also exists for children. So we'll go through that. There it is, yes. So essentially, I think it's not really area dependent. I would say most people would follow this, which is, again, the BTS guidelines. So this does exist for adults as well. So use questions, if they're already on Montelukast and high dose ICS, what does your area start? So, I mean, that's quite severe if they're on Montelukast and high dose ICS.
Yeah, I would think a child like that would be managed by a respiratory doctor, like a specialist.
That they would need a consultant,
rather than
consultant.
GP.
Yeah, okay. That would be managed in primary care. To be honest, if most children who are on an ICS and an inhaler, and Montelukast, I think, tends to be started by paediatricians, not routinely by GPs. It has quite bad side effects in children, like nightmares and things, and also not all children respond to Montelukast. It's kind of like some children respond to it and some don't. So this diagram is for chronic asthma. So essentially, I'll briefly talk about it now because we're on this slide. Everyone that's suspected asthma will be started on a low-dose ICS, so salbutamol or an Atrovent, and then they should be on a regular preventer if they have this if they have frequent wheezy episodes. Or if they're less than 5, they can be started on a leukotriene receptor agonist, which is your Montelukast. And then your initial add-on therapies are an ICS if they're not already on it. If they're over 5, you can then add your LABA, which is like your salmeterol, those type ones, or Montelukast. If they're under 5, then you can add an add your Montelukast, if that makes sense. And then your additional therapies, I think we've essentially the kind of ceiling of care is an ICS or a LABA or an LRTA. We don't tend to do anything else. If at that point you would refer to a consultant to consider other things. But yeah, that diagram is quite a good summary. And then what was the other question? Oral steroids. Do you ever use dexamethasone? So where I am, we use prednisolone. I don't know about other areas, to be honest, but where I am, we use prednisolone. I don't know if James.
Yeah, we use prednisolone as well. I know that there are a few paediatricians that do advocate for the use of Dex instead, and there are some quite good papers out there on it, as it being at least the same level of effectiveness. Most trust guidelines that I've seen say to use prednisolone at the moment.
And yeah, I think for us, the only thing that the guideline which for dexamethasone is croup, that we use dexamethasone, but for viral wheeze and asthma, we tend to use prednisolone. But I think they are equally as effective. So it would just tend to be wherever you work, what your trust guidelines would say. And then, what is your opinion on magnesium sulfate in a nebulizer? Oh, okay. I'll be honest. I've only seen it been given IV, so I don't know about you, James. I've only seen, and our protocols.
I've never seen it nebulized, but
yeah,
I'll have a little look while you're going through the next slides and see if I can find anything about it.
The BNFC has it in like a nebulized form. I've only seen it given IV, so sorry. Also, should nebulizers always be delivered via oxygen? I mean, I think in what I've seen, it depends on the oxygen saturation. So if they're needing it to be driven by, if the child needs oxygen, they combine the nebulizers with oxygen. But if not, they can just have it without oxygen. Do you agree with that, James?
Yeah, absolutely. So we only put the neb on via oxygen if the child's saturations are below what you'd expect them to be.
Yeah. On that topic, if a child's oxygen sats are low, which like we tend to say is 92% in these kind of cases, we do not give inhalers. We would always give nebulizers if they're on your kind of 1 hourly 10 puffs or 2 hourly 10 puffs, but their oxygen sats are low. You would give nebulizers, not inhalers, if that makes sense. Someone's put mega nebs get used in Glasgow, from what I've encountered, if that helps. I'm not sure. I don't know what mega nebs are, actually. But yes, we will. I think, James, have we missed a slide, or have we gone back one? No. There we go. So I briefly discussed about discharge criteria, but it's really important just to reiterate it, because so many of these asthmatic children go home as a failed discharge and then come to A&E the next day. So really important things is that you educate the patient on compliance and inhaler technique. So especially when we start a low dose ICS, which is a twice a day inhaler, the parents need to be told this is a twice a day inhaler, not to just use it when you get short of breath. And what a nice way that we tend to do it is that we say do it when you brush your teeth. So use your brown inhaler when you brush your teeth in the morning and when you go to bed before when you brush your teeth, because that tends to be quite a nice way. And I think it's quite difficult to often ask about compliance as well. So when you're asking about inhalers and compliance, a consultant told me quite a nice way of asking it is, in the 7 days of the week, how many days a week do you use your inhaler? And some of them might say 2 days a week, 3 days a week. So then you can establish how compliant they are. Inhaler technique is something that should always be done before a child leaves. So check they know how to use a spacer. And the nurses should be able to do that, especially pediatric nurses. They're really good at that kind of stuff. A Wheeze plan or a personal asthma plan will vary between trusts. Where I work, essentially, they can go home if they've been free from, I think this is nationwide, but if they've been free from nebulizers or an inhaler for 4 hours, they can go home. And we tend to discharge on a 6 puffs 4 hourly regime, and then they can be weaned down. So it goes from 10 puffs in hospital, 6 puffs on discharge, and then essentially weans down. But I won't go into the details because I think it varies between trusts. So just know that a Wheeze plan exists, and it's just a regime that weans you down on your salbutamol puffs. And all severe and life-threatening children would need a specialist referral. And these are also other reasons why you would need to do a specialist referral. So for any child that has failure to thrive, so they're not growing well, you would want to do a specialist referral. A persistent wet cough is a sign of something we call bronchiectasis, which can present in these kind of asthmatic children, and also a severe upper respiratory tract infection. But those children who don't need a consultant referral, they can have like a community nurse or a GP follow-up. And then it's really important that you talk to parents about things like smoking and stopping smoking, weight loss for the older children, and early prevention. So things like breastfeeding have shown to reduce the amount of respiratory lung conditions in children. So those kind of things are really important, as well as immunizations, etc. So yeah, was another question. What is your opinion on bronchiolitis in under ones who are present with Wheeze? I have a constant pattern with private practice as my doctor. Okay, I've mentioned this when I go on to talk about viral Wheeze. So essentially, there is a lot of debate as to whether bronchodilators actually work in children under 18 to 20 months. They actually do work in a select amount of children, So some children do respond to bronchodilators if they're under 18 months, but some don't. So there is no harm in doing a trial of a bronchodilator to see if a child responds to it, but quite often they don't. So there's actually no guideline to say not to use it or don't use it. I've been told that you can use it as a trial, but quite importantly in bronchiolitis, bronchodilators are not used. But if you've got a viral wheeze in a child under 18 months, there is no harm in trialing a salbutamol neb and see if they improve. If they don't, then you know that they probably haven't developed the receptors for bronchodilators. So yeah, trial and error. But when James has filed an article, which is good. Thank you. So this slide just talks about the different devices that we use for bronchodilators. So the first one looks like a spacer. So that's suitable for all children, kind of, this says under the 2 years of age, but actually older than that. A spacer is probably the best delivery for a young child. And parents can use it, so educating on how to use a spacer is really important. The second one is a dry powder inhaler, which we tend to give in children over 4 years. And then nebulizers we can give in all children, essentially. And then I've already gone over that very complicated slide. So the final case, sorry, we're running a bit over time, is a viral wheeze case. So this is a 2-year-old boy who presents to ED with a history of wheeze and shortness of breath. Prior to this, he had a cough and a runny nose for 3 days, but no fever. He's drinking fluids but has a reduced appetite. He had previous admission 6 months ago due to a similar episode, but no interval symptoms and no family or personal history of atopy. He was born at 35 weeks via normal vaginal delivery, and he has no pets at home, but father is a smoker. So on assessment, his oxygen saturation is 94% on room air. Heart rate is 135 and respiratory rate is 30. He's afebrile. On auscultation, he's got a scattered wheeze, transmitted airway sounds and subcostal processions, as well as a tracheal tug. He's got coughing and rhinorrhea, but is responding well to back-to-back nebulizers. So viral-induced wheeze. This is going to be probably, I would say, the most common presentation that you will see in children after the age of kind of 2. But obviously we do see it in young babies as well. Viral wheeze can be split up into 2 different categories. So you get your viral episodic wheeze or your multiple trigger wheeze. So your viral episodic wheeze is essentially wheezes that are triggered by a virus. And your multiple trigger wheeze, as is in the name, has multiple triggers. So it can be things like allergens, dust, hay fever, smoking, pets, those kind of things. And the multiple trigger wheezes are more likely to develop into an atopic asthma, which is quite important. The viral-induced wheezes tend to resolve by about 5 years. So the pattern is that your viral-induced wheezes, they are born with kind of not great airways, and then after the age of 5, their airways open up and get a lot better in a really simplistic form, a way of saying it. Whereas your asthmatics, they are actually often born with really normal airways, and then after the age of 5, their airways just get worse. So they kind of mirror each other in opposite ways in their kind of trajectory, if that makes sense. In terms of risk factors for viral-induced wheeze, things like being small for gestational age, being preterm or less than 2.5 kilograms, or maternal smoking. Those are really important things to ask in your history. Then we'll go on to signs and symptoms. So if there's an evidence of a viral illness preceding an onset of your respiratory symptoms, that is very typical of a viral-induced wheeze. So like a cough and runny nose, etc. And then you get your shortness of breath and expiratory wheeze. In your history, it's really important to ask about interval symptoms that we mentioned before, which in a viral-induced wheeze, you shouldn't have interval symptoms. And things like atopy, more likely in asthmatics, a preceding illness, triggers, if the child's growing and thriving, previous treatment from the GP, that's really important. So have they had steroids from the GP? Have they had nebulizers from the GP? So that's really important. And compliance with inhalers, so which I've already mentioned. And then your actual clinical assessment and initial management is exactly the same as for an acute asthma. So you don't have to learn 2 different treatments and managements, it's exactly the same. In children who are less than 3 years, who've had 4 or more significant wheezy episodes in the past year, they are children who are much more likely to have a persistent asthma after the age of 5. And it's if they have these following factors. So I actually got these from not my hospital's teaching guidelines, but children teaching hospital in Sheffield, which is quite a large paediatric hospital. So they say if you have these frequent wheezing episodes and you're under 3, you're more likely to develop persistent asthma after the age of 5 if you have one of the following: parents with asthma, a physician's diagnosis of eczema, sensitivities to air allergens, or positive RASTs or skin prick tests. Or you have 2 minor decisive factors, so like things like food allergies, more than 4% blood eosinophils, or wheezing apart from colds. So essentially there are various factors which can influence you then going on to have a persistent asthma. But these are the kind of things that you want to be looking out for. So with a viral wheeze, there are further investigations that you can do. There is no routine investigation that we would do for a viral wheeze. You would just want to make sure that their SATs are okay. And that is the only kind of investigation that you would need to do. Further investigations that you can do something called a video fluoroscopy, and what this is really good for is picking up things like silent aspiration. So a lot of children, they actually, with adults, it's a lot easier to pick up signs of aspiration and things like aspiration pneumonia, but with children, often the silent aspiration can present as a wheeze. And the main way that we actually diagnose that is doing like a video test, looking at the esophagus and the kind of airways to see if they are aspirating at all. And this can happen in like children who have kind of defective airways, or defective the kind of esophagus and things is not working as it should be. So this doesn't happen for all children that they get a video fluoroscopy, because this happens at tertiary hospitals. But if a child's having recurrent wheezy episodes, it's an investigation to consider. And the other things that you can consider are things like a bronchoscopy or a CT chest. And those things pick up things like bronchiectasis, which a chest X-ray wouldn't. Other things that you can do are blood tests. So like I said, if you see like an eosinophilia, that could indicate someone's more likely to develop an asthma and it also kind of dictates the severity of the viral wheeze. See if they're sensitive to at least one aeroallergen. So these 2 factors, eosinophilia and being sensitive at least one aeroallergen, these children are at greatest risk of developing asthma, and they're actually most beneficial to a daily ICS, and that's a study that showed that. So if you do spot that, definitely start a child with viral wheeze on inhaled corticosteroid. However, you should be cautious in starting steroids in mild presentations and in children less than 12 months, because they are found not to be entirely effective and have more harmful side effects. We can also consider azithromycin prophylaxis. So azithromycin is a kind of choice for prophylaxis for those that get recurrent chest infections. And it covers a very wide kind of atypical spectrum of bugs, which is why it's a choice. And there are a lot of children that are on this azithromycin prophylaxis. Like I said, a chest X-ray is only kind of required if there are kind of obvious or persistent asymmetry on auscultation or kind of unresponsive to treatment. Very importantly, if you hear crepitations on auscultation, that's not a reason to start antibiotics or do a chest X-ray, which I think is a mistake quite commonly done by GPs, is that they hear crepitations and start antibiotics. But quite often these sounds are just essentially retained secretions that the child cannot cough up, and they don't indicate an infection. They just don't have a very good cough reflex, so that's also really important. So this goes on to the question that someone was asking about response to salbutamol. So if a child is less than 18 months and not responding to salbutamol, which can happen because often we find that the actual beta-2 receptor agonists for salbutamol are not fully developed until after 18 to 20 months. Atrovent, which is essentially ipratropium bromide, may be more effective. So actually, we tend to give a trial of ipratropium more commonly than a trial of salbutamol. And many children in this age just don't respond to bronchodilators. This is actually what someone told me, that actually if someone is less than 6 months, you shouldn't routinely use bronchodilators. So that answers the question. If we've got time, if people are interactive on the chat, I just wanted to do a quick quiz. Hopefully everything that is on the questions should have been covered. But yeah, if you just use the chat function to put your answers down, I think that's probably the best way to do it. Okay. If anyone has any questions before we do the quiz, feel free to put them in the chat as well. Okay. So first question is, a wheeze is largely due to narrowing of what airways? Are they your extrathoracic or intrathoracic? Yeah, quite a few people have put B. Yep. So it's your intrathoracic airways, yeah, which gives you an expiratory wheeze. So the most common pathogen associated with bronchiolitis is A, RSV, B, rhinovirus, C, adenovirus, or D, parainfluenza. Yeah, quite a few people are putting A, so that's really good. RSV, it's a very common exam question. Well, this one's a bit harder. Which of these is not an absolute criteria for admission of bronchiolitis? So inadequate oral intake, less than 50 to 75%. B, severe respiratory distress. C, oxygen saturations of 92% in the early phase of the illness, or a pre-existing lung disease. Yeah, D is correct. A pre-existing lung disease is a relative criteria that you might, it's not an absolute criteria, but it's a relative criteria that you might consider admission, but not an absolute criteria. Which of these is not a key feature of asthma? So A, a polyphonic wheeze, B, interval symptoms, C, positive response to asthma therapy, D, personal and or family history of atopy, or E, a wet cough. Yep, E is correct. Most commonly, it will actually be a dry cough that happens in the morning or late night. And a wet cough, like a persistent wet cough, can be a worrying sign, and you might need to rule out something called bronchiectasis. But yes, someone has put quite correctly in the chat, asthma is a dry cough. In what age and above is peak flow accurate? Yep, C is 5 years and above. Routinely, we don't tend to do peak flows if they're less than 5 years. And when assessing severity of asthma in children younger than 5, we don't use that peak flow less than 33%, or 33 to 55% as well. Which of these is not a feature of life-threatening asthma? So A, PEFR 33 to 50% of predicted or best. B, hypotension. C, silent chest. Or D, oxygen saturations of less than 92%. This one's a little bit harder. And we're getting a mixture of answers. So a few people have said D and a few people have said A. So yeah, it is in fact A. So in a life-threatening asthma, it's PEFR, peak expiratory flow rate of less than 33%, whereas this one, 33 to 50%, is for your acute severe, not your life-threatening. But B, C, and D are all features of life-threatening asthma, yep. So this is in my trust, but I have routinely seen this, or I've asked consultants about it, and they've said this is the kind of common practice among most trusts in the country. So on what regime can an asthmatic or a viral-induced wheezer be safely discharged? So 10 puffs 3 hourly, 8 puffs 3 hourly, 6 puffs 4 hourly, or 6 puffs 6 hourly. Yep, 6 puffs 4 hourly is correct. I think this potentially might be the last question. In what age group can bronchodilators be ineffective? So A, less than 12 months, B, less than 24 months, C, less than 18 months, or D, less than 20 months. Again, we're getting quite a mixture of answers. So A and C, I think, is the majority. So yeah, the answer is C, less than 18 months. That is just what studies and papers have shown, is that less than 18 months, your receptors against bronchodilators are probably, your beta-2 receptor agonists have not actually fully developed if you're less than 18 months. But like I said, it's not a kind of thing that we cannot trial a salbutamol in less than 18 months. But routinely, if they're less than 6 months, we tend not to use them. But I mean, in that kind of age, we tend to trial ipratropium bromide more than salbutamol. I think that's the kind of take-home message. I think that might be the last question. So thank you everyone for listening. If you've got any questions, please put them in the chat. and we would really appreciate if you could fill out a feedback form, for us to know things to improve on. And you also need it to claim your certificate for attending. So thank you, and I think me and James will stick around for a bit if anyone has any questions. And I think the slides will be available.
Yes, that's right. I'll stick them on the event page on Medal, so they'll be uploaded there. And yeah, please do fill out the feedback form. That's how you generate your certificate. But it's also useful for our presenters' portfolios, and it's useful for us to improve future sessions. But thank you all very much for coming, and thank you, Dr. Abraham, for your session. I particularly enjoyed the quiz. I was upset I got which one. There was one just before the end I got wrong. I was quite disappointed with myself. I think it was the life-threatening asthma one.
Yeah, I think that could be quite a bit, because it's also different to the adult one. So there's like 2 to learn, which can be a lot.
And to Hafsa Hussein, yes, the session is recorded. It normally goes up on YouTube maybe a day or so after the session. So if you go on the Mind the Bleep YouTube page, you can find it there. Okay.